This time I thought we will make some case discussion and then go on to particular diseases and then the drugs so that you will be able to understand what is the real scenario than the real scenario. So first I thought let me take up some of these common things like cytochrome P450, then enzyme induction, enzyme inhibition, first pass metabolism. Likewise, we have several of these components along with prescription reviews and dosage errors, etc., which is very commonly seen in your CT exams and all those things, and also in day to day because each patient will ask you whether if we write amoxicillin 500, they say they have already taken it. So if you give an HP kit, it is the dosage differs. So these are the problems which are met, and whatever we write, even the pharmacy has a role nowadays. So these are the things what has to be tackled. So I thought we will take up like this and then come to drugs and diseases. Likewise, on case-based discussion. So I thought of having a case series which I've already told to sir, and we will see what best can we do depending on this discussion. Okay, so we will first talk about a case scenario. You note down the main points, though I read out everything. The 54-year-old female patient presented to emergency department, 6-hour history of shortness of breath, sharp right-sided chest pain, worse on deep inspiration, experiencing palpitations, not complaining of nausea, no lightheaded, and a history of DVT for which she was on lifelong warfarin. This is very important point. Then INR has been stable at 3 to 3.5 with 5 milligrams of warfarin once daily. You should know the characteristics of warfarin because that is the most cheapest drug. Though we have got a novel oral anticoagulants for more than an year and had been checked 4 weeks ago. Then the other past medical history was active pulmonary tuberculosis for which the patient has been prescribed first line drugs, that is HREZ. The patient worked as a primary school teacher and was usually fit and well. No smoking, no alcohol. There was no relevant family history. So now I want to catch up the main points in this history first, then talk about the normal anti-tubercular drugs and then the oral anticoagulants, where they are placed today, and then we will come to a conclusion what happened to this patient, why he developed pulmonary embolism, and then further we will see to it what best can be done with our drugs, because here it is only the drugs, nothing else can be done here. So we will see what combination of drugs or what else can be given here. So this is the whole content what I am going to speak about. So the patient appeared dyspneic on exertion, comfortable at rest, pulse was 110, regular, blood pressure stable, respiratory rate 22, afebrile. And these are the results of the blood test. And also one CT angio was done where we had to, where they saw that it was pulmonary emboli was also seen in that case. Okay, so this is the one what is expected. A CT pulmonary angiogram showed a large volume bilateral pulmonary emboli, but no evidence of associated right heart strain. So no heart failure, but there is bilateral pulmonary emboli. Okay, so these are the questions what we are supposed to answer. Before that, I want to take up some of these things which are related to drugs with this particular disease and then go on for further things. So what is the most likely reason for the patient developing a pulmonary embolus at this point of time, and how may this can be prevented? So we will answer these questions later, knowing the normal things first. So what is the overview of the case? The case name is cytochrome P450 system. So you should have that background because they are on polypharmacy. Patient is 54 years, young for the disease, old for the age. Presentation, shortness of breath, right-sided chest pain versus worsening on deep inspiration. No palpitation, no nausea, no lightheadedness. And medical history, DVT with long-term warfarin, diagnosis, active pulmonary tuberculosis, with HREZ and lifestyle, no family history, non-smoker, no alcohol. On examination, we have seen these things in the history itself. Then laboratory investigations also are quite okay. Okay. Then the last one, CT pulmoangiogram, large bilateral pulmonary emboli with no heart strain. Now, here in this case, we have two main drugs, that is rifampicin and warfarin. So, what are the characteristic features of this? Rifampicin is particularly an enzyme inducer. So what do you mean by this? See, liver normally is the organ of metabolism. Though we have other 5 organs, this is the main organ of metabolism in our body. So here we have cytochrome 450, non-cytochrome also. So these are mediated by oxygen mediated and through phase 1 and phase 2 reactions. And these reactions undergo by enzyme inhibition as well as enzyme induction. To tell you in a very normal way, our liver produces or has in everybody's body, there are about 100 to 200 enzymes at any given time. There are some drugs which can make 100 or 200 to 1000, or some drugs which can make 100 or 200 to 0 also, or there are some eatables or drinks which can be an enzyme inhibitor or enzyme inducer. Okay, so here what do you exactly mean by the word enzyme inducer and enzyme inhibitors? So, enzyme inducer, as I told you, they will increase the enzyme from 200 to 1000 or 1500 depending on the capability of the drug. So, what happens here is, because normally whatever drug we take, that will get metabolized with the 200 enzymes over a period of time, whatever we have thought or whatever is outcome of our clinical trials. Now, when we give these drugs, these have the capacity to multiply these enzymes. What those enzymes will do is, the because today is the day of polypharmacy, we will be taking multiple drugs, and what happens, this drug which is an enzyme inducer will increase the metabolism of the other drug, and but it takes at least 3 weeks. Once we start on the drug, it takes 3 weeks for full-fledged enzyme induction, and from there on onwards, what happens, the other drug what is there, instead of getting metabolized at the stipulated time what we have thought, it will get metabolized earlier, so that for whatever disease we have given the drug will not work out. That means to say in one word, there will be therapeutic failure. But there are exceptions to some rules. Only one of them. Till now, we have many, but to tell you very frankly, one of the drug, which is an enzyme inducer, is used therapeutically. But all the others, most of the others, we have seen a therapeutic failure rather than being used in therapeutics. Contrary to this, in case of enzyme inhibition, the enzymes become zero. So whatever drug we had given, the same drug will remain in the body for a very long time and causes toxicities. So accordingly, within a minute, you have to think in front of the patient whether to increase the dose or decrease the dose, or can give polypharmacy or no, or change the drug, or do you have any other alternatives. All these should flash in your mind the moment you see this sort of scenario. Okay, so in some cases we can change the drug, but in certain cases they are the primary drugs to be used, and so we cannot think of changing the drug. So alternatively, we should change the other drug. In certain cases, both of them cannot be changed. So in such cases, what better things can be done? That is the question today. Okay, most often it can be done with drugs, but sometimes these are the problems. So to name a few, the enzyme inducers, very commonly we see in today's practice where we are using it day in and day out, barbiturates. Out of that, we are using only thiopental sodium. We are not using phenobarbital. I told you phenobarbital is the only one which causes therapeutic positiveness. Why? Because phenobarbital is an enzyme inducer which is helpful in congenital hyperbilirubinemia or neonatal jaundice or kernicterus. See, normally all of us being born as human beings, in first to second and third day, all of us would have experienced the jaundice, which is known as physiological jaundice. If the child develops jaundice before the first day or prematurely or after fourth day and continues further, then we call it as congenital hyperbilirubinemia or neonatal kernicterus. So this, how to get out of this? So this bilirubin has to be metabolized and excreted. So how to do that? We cannot just take it out with pump or anything. So for that reason, what we do, we will see to it that the liver enzymes are increased. So how to increase? Phenobarbital is one drug which can do no harm at that particular time, and it is an inducer. So when it induces, it increases the enzymes and it will help in the metabolism of bilirubin. So what happens? The jaundice comes down, and so this is the pharmacological treatment of congenital bilirubin. But nowadays what people are doing, they are going directly to phototherapy. So these are the problems which are encountered. So you can be shrewd enough. If at all we are not in cosmopolitan cities, still these are the better drugs. Though phenobarbital is out now as a sedative hypnotic or as an anti-epileptic, it is totally out. We do not use anymore. But still, this has an use in case of pediatrics, in case of neonatal jaundice or congenital hyperbilirubinemia. Next, carbamazepine, as all of you know, it is a very wonderful, cost-effective anti-epileptic drug, but it is an enzyme inducer. So this, when given along with oral contraceptive pill, the effect of oral contraceptive pill decreases, and the patient comes back with the lady comes back with pregnancy after about 3 months, saying that she was taking both the drugs properly. Here the problem will be the neurophysicians also would not have asked about drug history, nor the gynecologist would have asked about drug history. So these are the problems, and oral contraceptive pills undergoes metabolism both in the liver as well as it undergoes enterohepatic circulation. Next, ethanol, which is a chronic misuse or abuse. This can affect the phenytoin, which is also an enzyme inducer. So it will decrease the effect of phenytoin. So what we should do as an anti-epileptic drug, which is also used, which is a sodium channel blocker, well, this is the drug of choice of phenytoin, except in reproductive age. This is a wonderful drug, but these are the problems when it is a male epileptic on phenytoin but chronic alcoholic. In such cases, these are the problems which are encountered. So you have to change the drug and see the other effects are not seen, like gum hyperplasia. Next, phenytoin with warfarin, what we are seeing just now, phenytoin, rifampicin or sulfonylureas, all are enzyme inducers where the effect will be on warfarin. These are about hepatic enzyme induction where we are using these drugs day in and day out. Coming to enzyme inhibition, the commonest ones, allopurinol in gout, okay, then cimetidine no more used because of anti-androgenic effects. Ciprofloxacin, which is an enzyme inhibitor, most commonly ciprofloxacin with theophylline we are seeing very common, but theophylline is not used nowadays because we have got wonderful inhalational drugs in asthma. Disulfiram, which is a drug for chronic alcohol dependence, again we have got another wonderful drug, so we are using something like naltrexone than disulfiram because of hypotension and other problems. Erythromycin, we do not use it now because we have got newer macrolides like roxithromycin, azithromycin, and clarithromycin. Then it has got an effect on warfarin. Those newer macrolides does not have so much of enzyme inhibition. Ethanol again can be both enzyme inducer and enzyme inhibitor. Isoniazid, which is an anti-tubercular drug. Omeprazole, which is given as a shotgun therapy by anybody and everybody nowadays, both oral, IV, everything, everywhere. So there are about 10 adverse effects of this PPIs where we have to be very careful because it is available even as over-the-counter drugs. Sodium valproate, which is an enzyme inhibitor. We have to be very careful because this is not only an anti-epileptic drug, but it is also used in bipolar disorders as well as migraine. So over-the-counter drugs, we have to be very careful. Then sulfonamides, almost it is outdated except for cotrimoxazole, and topical sulfonamides, especially for burns, where we use silver sulfadiazine, and some of them in ulcerative colitis, where we use this sulfadiazine, burns sulfadiazine, where it will break up into 5-ASA as well as sulfapyridine, where we can use it both in ulcerative colitis as well as IBS. So these are few of the glimpses what I have given to understand further what can result in our clinical scenario. Now, the next one is, at least you should remember some of the common drugs in in tubercular disease. I have just named the first line drugs, but nowadays we have got second line drugs, that is fluoroquinolones as well as aminoglycosides. Then we have got something known as MDR-TB. Then we have got stop-TB. Then we have got DOTS. Then we have got newer drugs like bidaqualin as well as damanalid. See, all these are the things what you have to remember. And but still in India, still we use these first line drugs itself. So you have to know little more than the others, because this is the only one combination where we are using day in and day out, and we are seeing extrapulmonary tuberculosis in every person. There is no bar for gender or age or area, urban, rural, whatever it is, we are seeing tuberculosis very commonly. So to name a few common side effects to remember day in and day out: isoniazid, very commonly peripheral neuropathy, so we are supplementing with pyridoxine. Hepatotoxicity, especially when they are alcoholic, and lupus-like syndrome. These are the three most important ones what we have to remember about isoniazid. Rifampicin, this is a wonderful drug where we are using in so many non-tubercular conditions also, but we have to be very careful because of more than hepatotoxicity. It is the enzyme induction where we are more bothered with rifampicin. Here, we can really find out whether rifampicin is being taken or not by the patient, because all the body fluids will be orange colored, but patient is likely to have flu-like symptoms, and enzyme induction is very common. And these two are the first line drugs, the most important drugs in tuberculosis, where we extend it even to 9 months, or if they are totally resistant to these, then we do all the investigations and later on taper it. Otherwise, these two are the most common ones which we use it in any case of tuberculosis. Pyrazinamide, the most commonest one is hyperuricemia. All drugs causes hepatotoxicity, but pyrazinamide causes hyperuricemia, isoniazid peripheral neuropathy, ethambutol optic neuritis. This is a very common question what we ask you. That is, ethambutol is never used in children below 6 years. Why is it so? Because this optic neuritis or field of vision or vision as such is a subjective. It is not objective. So because of that, the child, whatever we force, is likely to answer in the same way that compared to adults. That's why we are not supposed to use ethambutol in case of children below 6 years. Then streptomycin, it is almost outdated because it should be given IM daily. And the first symptom they develop is this one, vertigo. Okay, this is the first symptom what they develop, and more than hearing loss, the problem is vertigo. Because of this, we have stopped streptomycin, and we have all these four drugs which are wonderful drugs but should be taken most often in rural areas. It is under supervision. Otherwise, we can take up as 2+6 or 2+9 months. This is a glimpse. The second generation you have to remember, and then you have to remember MDR-TB, stop-TB, DOTS, then steroids in tubercular meningitis. Why it is given? For two main reasons. We are buying time. Corticosteroids are anti-inflammatory, and it will enhance the actions of these anti-tubercular drugs. So these are few of the things what you have to remember, and amongst them you have to remember rifampicin, because it is the most commonest one which is used not only in tubercular but also in non-tubercular conditions. And also the other alternative instead of rifampicin, which is an enzyme inducer, we use rifabutin, especially in patients who are HIV with TB. HIV with TB, we use rifabutin because that is not an enzyme inducer. This is an enzyme inducer. It will decrease the effect of all anti-HIV drugs. So we have to use alternatively these rifamycin or rifabutin. Now, coming to few drugs as anticoagulants and their effects, so that we can make out where is the problem, what is the problem, where we have to be really vigilant and other things. As all of you know, anticoagulants are divided into intravenous as well as, injectable and oral anticoagulants. Injectable are heparin, low molecular weight heparin, fondaparinux, then in HIT, that is heparin-induced thrombocytopenia, we have bivalirudin, heparin, all those things. We then coming to oral anticoagulants, the most commonest even today, though we are out with so many of newer oral anticoagulants, warfarin happens to be the commonly prescribed for many thromboembolic conditions. So this remains the most common prescribed therapeutic therapies in any of these complex diseases because it is quite cheap. But the problems are many. It has got too many drug interactions. Okay, and also the side effects are so many, and so you have to be careful while treating. Acutely treating, what do you use, and chronically treating, what do you use. If you can buy sometime, you can use something else, and if you cannot buy sometime, we use some other thing. And this is a pure vitamin K antagonist. That means it is blocking all the factors 2, 7, 9, and 10. And so you have to generate these factors 2, 7, 9, and 10, and also antagonize vitamin K. Two targeted phenomenons for warfarin. They will block vitamin K by, and also by that mechanism it blocks 2, 7, 9, and 10. So when they do this, and bleeding is the most commonest side effects of any anticoagulant if in these cases. So here warfarin causes mainly bleeding. That should never be forgotten. Cannot be given during pregnancy because of teratogenicity. Because of long term things, it may cause hepatotoxicity, sometimes their skin necrosis also, and obviously bruising because of its anticoagulant action. The newer ones are mainly dabigatran, rivaroxaban, apixaban, and edoxaban. In case of chronic any kidney dysfunction, we prefer apixaban. But normal oral anticoagulant, newer ones, what we use is dabigatran and rivaroxaban because we need not monitor INR ratio. So with warfarin, it is the following points should be remembered. It is vitamin K antagonist, blocks 2, 7, 9, 10, and it is more plasma protein bound drug. Plasma protein bound drugs will always remain as storage drugs. So as and when the free drug is getting metabolized, slowly the bound drugs is getting liberated. And this problem occurs in case of see, you have in pharmacokinetics, you have absorption, distribution, metabolism, and excretion. Absorption, we can somehow manage all the drug interactions, but we do not find many of the drug interactions with distribution. Why? Because blood is going all around the body, and when in each circulation, it is also going to the liver and getting metabolized. So we do not see too much of drug interaction, but still, whenever the two drugs occupy the same albumin site, there are too many albumin sites. If two drugs occupy albumin A and albumin B, no problem at all. But both the drugs want to occupy only albumin A site, then the problem starts. And there we have these sorts of interactions, especially in these emergency drugs or high risk drugs, where there's something like bleeding, hypoglycemia, hypotension. Okay, in all these cases, we see that it is an emergency and we have to be very careful. Because of these problems, nowadays most of them are using dabigatran or rivaroxaban, apixaban being holded only in case of kidney dysfunction. Okay, so these are few of the things what you have to remember. And in case where there is warfarin overdose, even after monitoring APTT, PT, as well as INR ratio, if at all there is overdose, we normally give vitamin K. But if it is an emergency, then you have to give fresh frozen plasma. Why? Because only plasma contains those factors. That's the reason. Where else can you use fresh frozen plasma? Whenever we require enzymes. Where do you require enzymes? Which enzymes are present in the fresh frozen plasma? in case of these pseudocholine esterase. Where do you find this problem? It is in succinylcholine apnea. Succinylcholine normally gets metabolized by pseudocholinesterase. In cases where there is pharmacogenetic abnormality, this sort of pseudocholinesterase is not there. Atypical pseudocholinesterase is there. Succinylcholine cannot get metabolized, so lands up in apnea. So patient should be treated with mechanical ventilation and fresh frozen plasma. These are the two conditions where two drugs where you require fresh frozen plasma, that is warfarin as well as succinylcholine. Fondaparinux, though these are the problems, it is most often given by IV. It is a factor 10 inhibitor. And these are oral thrombin inhibitors. Oral thrombin inhibitors. Now, what are the discussion points? First question was reason for pulmonary embolism. Why did this occur? Because drug interaction was there, because rifampicin induced CP450 enzymes. And even in that CP450 enzymes, it is mainly CYP2C19. CYP2C19 is one of the isoenzymes which is responsible for warfarin metabolism also. This induces, rifampicin induces CYP2C19 and warfarin gets metabolized by 2C19. So when there is increased 2C19, warfarin will activity causing reduced warfarin effect because of therapeutic failure. Next, prevention strategies are close INR monitoring during rifampicin therapy, adjust warfarin dose as needed. So the key points. Before going to the key points, I would like to highlight some of the good points what we really want to know. That is these are a few of the points what you have to take it into your consideration. First of all, warfarin and rifampicin will get metabolized by CYP2C19. They will get metabolized by CYP2C19. And secondly, instead of warfarin, because of these problems maintaining INR, bleeding, then polypharmacy, we have shifted to dabigatran and rivaroxaban. Then thirdly, because of plasma protein bound, if at all the patient is also a diabetic, then the sulfonylureas also get attached to the same albumin site. Or if we are giving analgesics, which is outdated drug now, that is phenylbutazone, these also bind to the same protein albumin site. So they also can cause increased warfarin in the blood. And so what can happen? This can release more warfarin, and so more anticoagulant effect, and hence more of bleeding can occur in those plasma protein bound cases, whereas here it is an embolism which can occur thoroughly. Okay, so though these are the problems, still we use warfarin, which is more commonly prescribed therapies even in complex diseases. Okay, so these are the few things. And this CYP2C19 is the main one which you have to remember. For many of these are the isoenzymes. And in dietary sources, you have to remember grapefruit juice, which is an enzyme inhibitor. So after drinking grapefruit juice, especially in elderly, if they take some of these drugs, they can have a prolonged action. I told you three main things what we encounter in our practice: hypoglycemia, hypotension, as well as bleeding, especially at night. So we may say internal bleeding, patient was all right, morning he died. So these can be the problems. So we have to remember these three important phenomenons. So here, what has happened? The patient was started on anti-tubercular antibiotic, that is rifampicin, which is a potent inducer and isoenzyme for responsible for warfarin metabolism, and also this is metabolized at a faster rate, reaching the subtherapeutic levels, and hence the patient developed the pulmonary embolism. Also, warfarin has got a narrow therapeutic index. So, the patient was on 5 milligrams. So, even if we increase by 5.5 or 6 milligrams, there may be lot of bleeding. Because they are taking rifampicin, it's a therapeutic failure. Otherwise, they can cause total internal bleeding, and the minor change in dose will lead to more than subtherapeutic levels. It leads to toxic levels, and there in such cases we normally give vitamin K as antagonist, and it inhibits the vitamin K synthesis of clotting factors. So in such cases, you give vitamin K, but it takes a long time. In such cases, we give fresh frozen plasma, and we have to keep on measuring. The INR measurement is very necessary, and to see the effectiveness of the drugs and in affecting the prothrombin time. So whenever we induce these CYP inducers or inhibitors are given, we have to monitor these INR ratios or whatever is in that scenario. So we have to be very careful, or decrease the dose of the drug, or change the dose of the drug, or adjustment is necessary still till the patient is stable on the therapies. So once they achieve the therapeutic level of warfarin, then we can. Why do we add heparin in presence of warfarin initially? Because warfarin has got the onset of action. See, you have to remember three things. One is onset of action, one is duration of action, one is end of action, and peak of action. So these are the things what you have to remember. Warfarin onset of dose is minimum 3 days. So within 3 days, there can be pulmonary embolism again. So for that reason, you have to see that we have to see that anticoagulant effect is there. So most often we give heparin. So start with heparin, then again start with warfarin, continue warfarin, and discontinue heparin after 3 to 4 days, where warfarin onset of action is increased. And so you see that you will achieve a therapeutic target, whatever you have thought so. And so you have to be careful about this enzyme induction and inhibition in these cases. So, because we have to see all these, and patients are very busy, etc., etc., etc. So now we have shifted on to oral thrombin inhibitors. Can you change any of the drugs in tuberculosis in this case? When the patient is on rifampicin and warfarin, or first line anti-tubercular drugs and warfarin, can you change it? No, we cannot. We cannot change tubercular drugs, because these are the drugs of choice unless and until there is a resistance. Until and unless there is a resistance, these are the main drugs of choice what we see, and these are the ones what we really need also. So for that reason, you have to think whether we can continue with warfarin, or anyhow the patient is on deep vein thrombosis. The alternative, if the patient can afford, we can use even subcutaneous low molecular weight heparin. But nowadays, these are the ones which are used, oral thrombin inhibitors, where we need not monitor INR ratio, and patient can also be free, except if at all, if they are very old or kidney dysfunction is there to that particular age. Don't generalized kidney dysfunction at any given time. Physiologically itself, at 55th year of age, there is 5% decrease of GFR. So you can have 5% decrease over a period of time, and you can see at that particular age what can be the GFR. Depending on that, you see and calculate, and then adjust the dose of the drug. Otherwise, it has no meaning just by seeing all these things. So to come to a conclusion, the CYP system is a family of isoenzymes that are responsible for the metabolism of many drugs, what I told you or what I showed you in this slide. So again, to revise, you are seeing allopurinol, anti-gout, cimetidine, anti-ulcer, ciprofloxacin. Nowadays, no more use, though it is the drug of choice in typhoid fever, disulfiram, or we have got too many fluoroquinolones now, a respiratory fluoroquinolone, an ophthalmic fluoroquinolone, okay, and then gastrointestinal fluoroquinolone. We have too many drugs, ciprofloxacin, but still it is the best drug of choice, especially in skin and soft tissue infections, especially when the patient comes with cellulitis or even diabetic ulcers, where we can trim the ends and then start with, if they have got too much of organisms after culture sensitivity, we can start with ciprofloxacin, metrogel, and gentamicin. This combination works wonderfully along with chimarol forte. So and if at all, if it is cellulitis, give them this anti-edema measures, magnesium sulfate liquid. So these five things will work out wonders in cellulitis even today, but it should be administered properly with proper prescription, proper dose, and proper duration. Then disulfiram, as I told you, this was the drug of choice in chronic alcohol dependence, but we have to admit the patient and do all those things. So we have shifted on to naltrexone, ondansetron, acamprosate, etc. The erythromycin, this also causes increased peristalsis. So that's why when they take erythromycin, they can experience diarrhea also. But because of four reasons, we are not using erythromycin now. Though it is a very good drug, we are using only in skin conditions as ointments. So this four problems with erythromycin is it is an enzyme inhibitor. It has to be given 4 times daily. Okay, and only estolate is the one which can be used, and it causes gastritis. These are the four problems which are which are a big problem. So we are using most often left and right azithromycin now, so that we are combating this antibiotic resistance. And so everywhere and anywhere this antibiotic stewardship is going on, because it is something like a old wine in a new bottle. If we would have thought how to use antibiotics, this would not have occurred, because we do not know how to use antibiotics and we use for anything and everything. This is the problem what we have encountered. And so this new phenomenon of the antimicrobial resistance and antibiotic stewardship has come into existence. Ethanol, all of you know, very fond, but still the problem exists. And most of the scan phenomenons, we see that fatty grade 1 fatty liver, because of these things where they drink day in and day out, and in whatever conditions they are. Isoniazid is a wonderful drug, only drug for tuberculosis. Omeprazole, as I told you, there are about 10 adverse drug reactions. The most common ones are achlorohydria. First is achlorohydria. Second is infections. Third most important nowadays, what is encountered is acute kidney injury, AKI. Acute kidney injury is most often encountered. Later on comes decreased calcium absorption, osteoporosis. All these will come, there are a lot of drug interactions with omeprazole, because it is an enzyme inhibitor. So we see toxicity of the other drugs. And nowadays, all of you see with all the super specialists, omeprazole, one B complex, and one sedative hypnotic is the most common one what is written. So in any case of anti-ulcer drug institution, and especially nocturnal, still ranitidine, though it has got many problems nowadays, still ranitidine is the wonderful drug where we can give 300 milligrams at night time, where it is supposed to take care of nocturnal acid secretion, and so the patient will be done with it. And nobody asks for any of these modifying factors what we used to have those days. And we also do not tell, patient also do not listen. So these are the problems what we meet. And sodium valproate, as I told you, this has got non-epileptic uses also. But in BPD and other things, we do have better drugs. But still, we can use valproate except during pregnancy, where it has got spina bifida as the problem. And also, it's an enzyme inhibitor. And in normal cases, even alopecia is very commonly seen. So because of these, we try to restrict, though it is a broad spectrum anti-epileptic drug. Broad spectrum anti. There are few of the broad spectrum drugs in pharmacology. One of them is sodium valproate, which is a broad spectrum anti-epileptic drug. Broad spectrum antibiotic is chloramphenicol even today. Even today, chloramphenicol and tetracyclines are the most common broad spectrum antibiotics. So we have some 10 to 15 drugs of broad spectrum uh, broad spectrum drugs in pharmacology. One amongst them is sodium valproate. Sulfonamides, it's almost the days have gone. Rarely we find sulfacetamide as topical eye drops. Mephinide, we don't use mephinide for lactic acidosis. We use silver sulfasalazine in burns, and sulfadiazine in ulcerative colitis. Sulfamethoxazole with pyrimethamine in malaria, and sulfamethoxazole in trimethoprim in as cotrimoxazole, especially in pneumocystitis, Jerovisi infections, and also in chronic UTI, where we give it even for 6 weeks also. And trimethoprim is still the only drug of choice in chronic prostatitis, because that's the only drug which can enter into prostate rather than other drugs. And this is the most dangerous area where we still encounter even today, where we have resistant UTI in males, and also resistant and recurrent UTI in males because of prostate problems. And this is still the only drug which can penetrate into prostate. Sulfonamides, I told you these are the few things. Otherwise, we don't have any role in sulfonamides because they are known to cause physiological teratogenicity. That means they can cause jaundice. Anatomical teratogenicity within 3 months, and so the game is over. But from 3 to 9 months, we have got physiological teratogenicity, where we have got umpty number of drugs which can cause, the most common one being morphine, where it causes respiratory depression. Instead of the child crying, it better goes to sleep permanently. So these are the few problems which are encountered. And as I told you, enzyme inducers, barbiturates, only two drugs are used. Other drugs are not used: thiopental sodium and phenobarbital. Carbamazepine, one of the best anti-epileptic drugs apart from phenytoin, ethosuximide, carbamazepine, and sodium valproate. Nowadays, we have got add-on drugs like clobazam and clonazepam as benzodiazepines, and newer anti-epileptic drugs like levatricitam, lamotrigine, gabapentin. Then we have tigabayne, etc. Phenytoin, again a sodium channel blocker, which is used non-epileptic use, being uh, second drug of choice in digitalis induced ventricular arrhythmias. The first drug being lignocaine, but cannot be used in atrial arrhythmias because there is no sodium channels in atria. It's only slow calcium channels. This is the reason why we cannot use lignocaine in atrial arrhythmias. We always use lignocaine in especially in digitalis induced ventricular arrhythmias. Rifampicin, we are using mainly as anti-tubercular drugs, but certainly we use it in MRSA strains, okay, and in all the other conditions where we are using it very commonly, these rifampicins. Sulfonylureas, amongst all the old generation and newer generation, the most common ones which we are using is glimepiride, which has got least enzyme induction action. Post receptor actions are there, and no hypoglycemia to a very great extent, provided you don't use it more than 3 milligrams. And it has got very good effect, and it is a poor man's drug, so to say. Sulfonylureas and pioglitazones are poor man's insulin, what we can say. And this can be done if at all we spend time with the patients with their diet counseling specially, and then taking the drug properly. 30 minutes means 30 minutes. The food should be in front of them, then take the drug, wait for 30 minutes, and then take it. There will be wonderful control of both HbA1c as well as sugars. And the patient can be even on 25 years, even with just 1 milligram of glimepiride, also what we have seen very commonly. So these are the points what to be seen with whenever we use this SIP system. Then enzyme inducers will lead rapid metabolism of certain drugs and will lead, not impair their effects. It is a therapeutic failure. Outright, it is therapeutic failure. And with enzyme inhibitors, it is always toxic effects, what we see very commonly.